Welcome to the Virtual Cardiology Congress sponsored by Johns Hopkins University School of Medicine on CardioCare Live. My name is Dr. Lawrence Appel, and you are tuned into a live session called Hypertension Management in Challenging Patient Populations. Are we improving our clinical practice? Before we get started, I would like to remind our audience that I will be taking questions in real time throughout each presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. Great. More specifically, my title is Hypertension Management in Challenging Patient Populations, Diet, Drugs, and Devices. I'm a professor of medicine at Johns Hopkins University, and I direct an interdisciplinary unit called the Welch Center for Prevention, Epidemiology, and Clinical Research. By training, I am an internist and practiced medicine for over 20 years. Actually, 30 years. Next slide, please. Okay. So I do have two disclosures. I received some research support from McCormick Foundation, and there is an institutional conflict of interest with Healthways, a disease management company. I'd like to start with a case, and this is an actual patient of mine, a 65-year-old African-American woman with difficult-to-control hypertension, notable for labile blood pressure, often as high as 165 systolic over 90 diastolic. She has had an intolerance to several medications, Vasotec, Ramipril, Losartan, Tenormin, Kalen, Hytrin, Adalat, Clonidine, Hydralazine, Spironolactone. Her current therapy is amlodipine 10 milligrams a day, eplerenone 50 milligrams per day, and Efferk 25 milliequivalents per day. And actually, one of the more interesting aspects about her management is that she has had problems with hypokalemia even on very high doses of potassium, and I'll get to that in a second. One other point to make is that she has required potassium replacement, and in contrast to what many of us have used, potassium chloride tablets or liquid, we used Efferk, which is a very very well tolerated potassium supplement that many patients of mine prefer. So as I indicated previously, she has several interesting features, one of which is hypokalemia. And numerous times she has had low potassium level, even while on a potassium-sparing diuretic, and even while on high-dose potassium replacement, up to 100 milliequivalents per day. So for this reason, we had worked her up for hyperaldosteronism. She had a low plasma renin activity of 0.2 nanograms per ml per hour, high serum aldosterone of 20 milligrams per deciliter for a ratio of 100, which is extremely high. So at this point, we were concerned about an adrenal lesion. An abdominal CT scan revealed a 5-millimeter nodule on her right adrenal gland. We were concerned about a unilateral adrenoma. However, when we did adrenal venous sampling, the pattern really suggested bilateral adrenal hyperplasia. She also has blood pressure-related end organ damage. In 2002, she had a TIA with right arm weakness. She also has evidence of chronic kidney disease, stage 3. Her creatinine was actually appears to be normal, 1 to 1.2, but as we all know, that degree of creatinine elevation is actually associated with a modest reduction in GFR. And her estimated GFR, depending on her creatinine level, ranged from 50 to just over 60 mLs per minute, suggesting that she has some end organ damage related to blood pressure. And as an aside, while the kidney disease that she has might be related to blood pressure, it's probably best to call it hypertension-associated renal disease, because there could be genetic causes for this, such as ApoL1 or MYH9 abnormalities. Interestingly, she has just a urine protein to creatinine ratio of 0.23. She does not have extensive proteinuria, but slight protein in her urine. She has been worked up for cardiovascular disease. Her echocardiogram was negative, however, for LVH, and she had an exercise stress test that was negative for ischemia. Here is a sample of her more recent blood pressure readings, and this you can see that they're from the top, which are her clinic readings. There is lability manifest by a systolic blood pressure ranging from 120 in clinic to 152. At the bottom, I provide her mean ambulatory blood pressure readings. Her 24-hour reading was 120 systolic over 77 diastolic with standard deviations in parentheses. Interestingly, her nocturnal blood pressure or nighttime blood pressure, which is on the lowest row, was only modestly reduced from her daytime blood pressure, less than 10%. So this is a person who has what one might call a non-dipping pattern. Now, this is a 2x2 graph of patients similar to her who have hypertensive chronic kidney disease. It's a scatter plot of nighttime systolic blood pressure on the y-axis by clinic systolic blood pressure on the x-axis. And you do a 2x2 grid. There are a fraction of individuals, 37% in the upper right-hand corner, who have sustained hypertension, and then 18% who have normal blood pressure. What is interesting, very few individuals with hypertension-related chronic kidney disease have white coat hypertension, which is really more of a phenomena in individuals who do not have major end organ damage. In contrast, in the upper left-hand corner, masked hypertension, which is characterized by a normal clinic systolic blood pressure, but elevated nocturnal or ambulatory blood pressure, is extremely common in patients with chronic kidney disease, and is the phenotype that we identify when we obtain out of clinic measurements. So with this case in mind, I wanted to cover the objectives of these objectives. First is to highlight recent advances related to lifestyle modification as a means to lower blood pressure. Secondly, diet as a means to reduce racial disparities. Thirdly, resistant hypertension. And fourth, the target blood pressure. How low should we go? Finally, I will cover future directions. And I realize that I have the opportunity to answer questions in the middle of the presentation, and I encourage you to do so, and I'll stop after each section and take questions. So I was fortunate to be one of the principal investigators involved in the Dietary Approaches to Stop Hypertension trial, which also is the name of the diet that we tested and that proved so effective in lowering blood pressure. And the effects of the DASH diet are actually pretty striking in terms of blood pressure reduction. Those are listed in the lower line of this figure, which document that, at least in the context of a controlled feeding study, blood pressure in individuals with stage 1 hypertension can be reduced by as much as 11 millimeters of mercury systolic just through diet alone. And this, to me, emphasizes something that is probably not as well appreciated by clinicians, but that diet and lifestyle modification does have the potential to dramatically lower blood pressure and control hypertension. I want to now move on to salt, which has gotten some considerable attention recently. And I call your attention to a recent publication that I co-authored on salts, sodium blood pressure and cardiovascular disease, published this past month in Circulation led by Dr. Paul Welton. And this summarizes the most recent evidence. Some of it has been paradoxical and likely related to major methodologic shortcomings of cohort studies. So on this slide, I've tried to list all of the major potential benefits of sodium reduction. On the left column, I list blood pressure-related benefits on the right column, blood pressure independent. So there's the potential for sodium reduction to prevent cardiovascular disease through both blood pressure related and blood pressure independent pathways. The same is true for stroke, left ventricular hypertrophy, and kidney disease progression. There are also blood pressure independent benefits of sodium reduction, including a reduced risk of kidney stones documented in a major multifactorial trial. The potential benefit of sodium reduction on osteoporosis. I realize that this is a cardiovascular audience, but sodium reduction, as sodium is reduced, so is urinary calcium excretion, and it's believed that although we don't have firm clinical trials, that sodium reduction could also prevent osteopenia. And finally, sodium reduction is associated with a reduced incidence of gastric cancer, and it might be one of the reasons why Southeast Asian in particular, they have a high incidence of gastric cancer, is because they also have an extremely high sodium intake. Now, what is the evidence on sodium and blood pressure? There's a variety of types of evidence, including epidemiologic, observational studies, migration studies, and genetic studies. Virtually all genes that have been associated with blood pressure appear to impair the kidney's ability to excrete salt. Also, there are numerous animal studies. Interestingly, despite some of the controversial findings of cohort studies in humans, there is no study in animals, except for genetically modified animals, that has documented harm from reduced sodium intake. And of course, there are clinical trials of sodium reduction on blood pressure, and then population intervention studies in northern Japan and Finland, where there's been a markedly reduced risk of stroke concurrent with sodium reduction efforts. Now, these are findings from meta-analyses that document that sodium reduction can be particularly beneficial. They are the average benefits in children, and these are children who are non-hypertensive adults, where the benefits might be preventing hypertension in the long term, hypertensive individuals, and individuals with resistant hypertension. Now, I'm going to cover the last column later in my talk, but I'd like to mention that the column on the right is particularly relevant to a large subgroup of individuals who have poorly controlled hypertension on multiple medication. And there was a very well done, albeit small, feeding study done at the University of Alabama, where individuals with inadequately controlled hypertension on 3 medications achieved a blood pressure reduction of nearly 23 systolic and 9 diastolic from reducing sodium intake by 2,300 milligrams. Large reduction in sodium, but also the benefit was substantial. So this is a slide that's perhaps relevant to the general population of individuals who are pre-hypertensive or have stage 1 hypertensive. Results from a controlled feeding study, a dose-response study. So if you look at the top line, you see that within the context of a more typical American diet, as sodium is reduced, so is blood pressure by an average 6.7 millimeters of mercury. In individuals consuming the DASH diet, which is a very healthy diet, which in itself lowered blood pressure, you still see blood pressure reduction going from, on the right, to a high sodium intake of 3,300 milligrams to a level of 1,500 milligrams on the left. And the lowest blood pressure is that actually achieved on individuals who are on both the DASH diet and reduced sodium intake. And here the blood pressure reductions are average 9 millimeters of mercury systolic, which is substantial and has huge public health implications. So there are factors that are associated with greater blood pressure reduction from a lower sodium intake, and these are fixed factors: African Americans, middle and older age persons, genetic factors in individuals with hypertension, diabetes, and chronic kidney disease. But there are also modifiable factors, and in the context of these factors, sodium elevates blood pressure to a marked degree, and that is in the setting of low potassium and a poor quality diet. Now, on the next few slides, I'm going to actually display average blood pressure reductions in some of these subgroups. So this is a subgroup finding from the DASH sodium trial, which documents that on average, blood pressure is reduced by 8 millimeters systolic in African Americans and 5.1 millimeters systolic in non-African Americans. Both groups benefit, but the average blood pressure reductions are greater in African Americans than non-African Americans. This is the corresponding results in people who are hypertensive, 8.3 millimeters systolic blood pressure reduction in hypertensives compared to 5.6 in non-hypertensives, and again, reductions in both groups, but greater reductions in hypertensive individuals. And a similar pattern in people who are over the age of 45, middle and older age individuals, in which the average systolic blood pressure was 7.5. And this is really important because the many patients seen by internists and cardiologists are middle aged and older age, and there's a very clear interactive effect. And I suspect, although there have been fewer studies in older age people, that the blood pressure reductions from sodium are particularly striking, and this is important given the high absolute risk of cardiovascular disease, particularly stroke and CHD in this group. And in this case, I do have a graph from one dose response study that explicitly tested the effects of sodium reduction in the elderly, and in this case, individuals with isolated systolic hypertension, and what you see is a clear dose-response relationship, particularly for systolic blood pressure. In this case, this is the subgroup that had systolic diastolic hypertension, and again, you see the same relationship. Now, it is very challenging to conduct clinical trials of sodium reduction in the general population, so we have few randomized trials with clinical outcomes. So the benefits of sodium reduction are largely based on extrapolations from the blood pressure reduction that you would anticipate. Basically, sodium reduction lowers blood pressure, and then you apply that sodium reduction to estimate the benefits in terms of prevented heart attack, strokes. And so this has been done by several researchers. Bimmons Domingo did this and published her results in the New England Journal 2 years ago, documenting that modest reductions in sodium should have huge benefits in terms of preventing heart attacks, and this is on par with what would be anticipated for drug therapy for hypertension, smoking cessation, or 5% weight loss. Now, as I mentioned earlier, there are few clinical outcome studies. These are very challenging to do of lifestyle modifications. It's not just true for diet, but we don't have trials of physical activity on cardiovascular outcomes in general populations, nor do we have completed trials of weight loss in general populations. So this is a meta-analysis of trials not originally designed to test the effect of sodium on CVD. So we have to interpret these cautiously, but we do see a tendency towards benefit as indicated in the lower bar in this meta-analysis. So we see directionality that we'd anticipate based on this reductions in blood pressure that we have documented. Now, very important is that excess sodium intake is ubiquitous throughout the population. As you can see in this graph, the orange bars are men, the yellow bars are women. We see very high level intakes, particularly in young adults, and with progressive reductions by age. And this is largely related to calorie intake. As calorie intake decreases, so does sodium intake. They're very tightly linked. And so that's what accounts for the differences over age and between men and women. Now, where does sodium come from? Most of it comes from food processing. Only about 12% is inherent in food, 6% is added at the table, only 5% added at cooking. And so when we tell our patients to cut out the sodium, cut the shaker, it really is not putting that much of a dent typically into sodium intake. Individuals really have to focus on the major sources of sodium, and that unfortunately are products that only modestly elevated in sodium, but because we consume a lot of them, the total amount of sodium is quite substantial, and that's indicated on this slide. I apologize because I recognize it might be a bit cluttered, but bread and cereal products, along with processed meats, chicken and poultry dishes that are like casseroles, provide a large chunk of the sodium that individuals consume, but it is almost ubiquitous in our processed food supply. So I do want to provide a glimpse of the next frontiers in terms of possible diet effects on blood pressure. Carbohydrate is one nutrient where I have a personal interest or personal research interest both in the amount of carbohydrate and type of carbohydrate. And so this is based on considerable work done in animals, particularly the role of sugars. And there's an interesting article in the Annals of Internal Medicine dating back to 1983 that examined the role of carbohydrates and blood pressure. And it's interesting that as I mentioned earlier, that if people are interested in salt-sensitive hypertension, this article highlights that at one point in time there were researchers interested in carbohydrate-sensitive hypertension. And the potential mechanisms could be salt retention. However, there are few studies in humans, cohort studies that are plagued by measurement issues, and very few trials, and that were often small with inconsistent results. So we actually have done some studies in this area where colleagues of mine or fellow researchers have substituted in meticulously done feeding studies, substituted carbohydrate with soy-based protein, mixed protein, lean meat, monounsaturated fat. And in each case we reduced carbohydrate but increased one of the other nutrients. And in each instance we documented net reductions in blood pressure. So it does raise the issue about whether the results occurred, for example, from increasing soy protein or reducing carbohydrate, or increasing mixed protein versus reducing carbohydrate. Since in each instance there were reductions in carbohydrate, I hypothesize that it's the reductions in carbohydrate that might have led to the blood pressure reductions. So in one of our clinical trials, termed Premier, we also examined the effect of sugar-sweetened beverage, and in this instance we documented that as individuals reduced their sugar-sweetened beverage intake, there were also reductions in systolic blood pressure. This is not a randomized trial, but it provides some hypothesis generating data that reduced intake of sugar-sweetened beverage might also have beneficial effects on blood pressure. Now, whether this is reduced as a result of the carbohydrate in these beverage or some other nutrient such as phosphorus, we can't say for sure. At this point, I also want to comment on opportunities to reduce racial disparities in blood pressure through diet change. This is an area of particular interest to me. It's also of tremendous societal interest given the huge disparities in health between various subgroups, particularly African Americans and non-African Americans. And it's very interesting because we have data that we can act on. We know that that the blood pressure of African Americans is particularly sensitive to lifestyle modification and dietary changes, and I'm going to show you that on the next few slides. So this slide is again from the DASH sodium trial, and it documents that, that reduced sodium intake has a greater blood pressure effect in African Americans than non-African Americans. Again, both benefit, but African Americans have a greater blood pressure reduction. And very importantly, the DASH diet also has greater blood pressure effects in African Americans compared to non-African Americans. Both groups, again, benefit, but more so African Americans. Now, one might ask, well, what aspect of the DASH diet? Was it fruits and vegetables? Was it the increased dairy or calcium intake? It's almost impossible to say for sure, but there's one nutrient that seems to be more effective in lowering blood pressure in African Americans, and that is potassium. And it's one of what I'll call it a stealth nutrient. It's not particularly well studied, well publicized, but my sense is that there are a lot of health effects of this particular nutrient, health benefits, and that we have yet to elucidate. And I'm going to now finish off my presentation with a discussion of resistant hypertension. And if I just call your attention to this statement from the American Heart Association, Resistant Hypertension Diagnosis, Evaluation, and Treatment, a nice paper that summarizes a complex area. So it's important to define it. Not in particular for research purposes, but it also helps clinicians as they try to classify their patients and then seek guidance. So it hasn't been well classified before, but this is what is now an accepted definition, which is in a blood pressure level above goal, despite concurrent use of 3 agents of different classes, one of which is a diuretic. So the prevalence is approximately 20 to 30% of hypertensive patients and roughly 40% of chronic kidney disease patients. Very tough to nail down the prevalence, but it is quite common. So the evaluation of resistant hypertension is probably what you would expect. Key issues are first, non-adherence to blood pressure therapy, and second is secondary causes. People typically do not volunteer that they're not adherent, and so when I evaluate patients, I try probing by just asking a non-threatening question such as, lots of people have difficulty taking their medications. Do you ever have a problem remembering to take your medications? Do you ever forget your medications? And some probing might reveal a positive response. One thing I learned during my residency that I find helpful is that it also can be useful to ask a patient to just bring their medications to the office and take them while they're in the office, so that you take medication so that the blood pressure is recorded before and after taking medications. A third sort of hint that in evaluating for non-adherence are sort of patterns of prescription request, and I'm sure I'm not alone in getting the request for medication the day before the medication runs out, and seems to be a surprisingly common request at patient visits, and probably indicates that people are trying to avoid refilling medications, potentially because of cost. Other problems with resistant hypertension relate to the drug therapy that's being used. When I am concerned about somebody with resistant hypertension, I want to make sure that they are on a diuretic, and ideally I put an individual on a long-acting thiazide such as chlorothalidone, which is my preferred diuretic. I usually start at a dose of 12.5 milligrams, which is half of the smallest pill. And then I often have to add a mineralocorticoid receptor antagonist, and the 3 that are commonly used are spironolactone, amiloride, and eplerenone. I personally have experience with both spironolactone and eplerenone. I mention amiloride because of a colleague of mine, Dr. Graham McGregor, who says that in Great Britain he's had great success using amiloride, even though it is not that commonly used in the United States. Now, as I mentioned earlier, reduced sodium intake might be particularly beneficial in lowering blood pressure in patients with resistant hypertension, so I put the results of the trial that I mentioned before, the short-term feeding study on the left. There are also two more invasive approaches which are carotid baroreceptor stimulation and renal artery denervation. In the latter, the column on the right is from an early Simplicity trial. I recognize that there is an ongoing clinical trial at this point testing devices to control resistant hypertension. But one thing I can point out that diet on the left might be just as good as some of these devices. At least there's preliminary evidence to suggest that. Blood pressure level, how low to go? So this has been almost a timeless question, something that I was interested in 30 years ago when I started my residency training. We have, I think, a reasonable answer from the Accord study, which is of close to 5,000 individuals with type 2 diabetes. They had two randomized goals, one less than 120, one less than 140, and the primary outcome was a composite of non-fatal MI, non-fatal stroke, and death from CVD. And as you can see on the right, they did achieve a striking contrast in blood pressure between the usual and more aggressive groups. But that did not translate into outcomes. For CVD, stroke, MI, and CVD death, the benefits were marginal at best. Interestingly, for the stroke in the upper right-hand corner, it was statistically significant, but wasn't one of the primary outcomes, and it was delayed over time. An important caveat to this clinical trial and a lot of recent trials is that the baseline rates of cardiovascular disease events have now dropped considerably, possibly related to concurrent medical therapy, so that even though patients in this study where there was a marked contrast between a usual and more aggressive blood pressure level, there was also concurrent statin therapies and/or aggressive diabetes control. So it's been increasingly difficult to document benefits because of fewer outcomes. This is results of a clinical trial where there's a hint of a benefit, and these are the effects of a lower blood pressure goal on patients with chronic kidney disease stratified by their level of proteinuria. And there's now, I think, reasonably consistent evidence that among individuals with diabetic individuals with proteinuria and non-diabetic individuals with proteinuria, that there is a benefit of a lower blood pressure goal. In this case, it was roughly 130 systolic. There will be guidelines coming out from NHLBI, and we'll be very interested in whether they overall advocate a lower blood pressure goal in patients with proteinuria. For my patients, I certainly would advocate it based on, I think, the available evidence. I don't see any major trials being completed in the next 5 years. There is the SPRINT clinical trial, which will address this issue, but I don't think they're going to have as many clinical outcomes as the ASK study. So I think, given the available evidence, I would push an aggressive blood pressure level in patients with proteinuria. There also might be benefit in patients with chronic kidney disease from Ramipril, which reduced the progression as shown in the lower line, the yellow line in this graph. So here's some unresolved issues regarding drug therapy for elevated blood pressure. What should be the goal blood pressure in patients without diabetes? The Accord study documented no clear benefit in patients with diabetes, so I think that we need to answer that question in patients without diabetes. I think this is perhaps the number one issue, unresolved issue that related to blood pressure-related target organ damage. Namely, does reducing blood pressure prevent cognitive decline? There's a reasonable body of evidence from observational studies that lower blood pressure in middle age is associated with fewer abnormalities on MRI, brain MRI, and there's actually now in the SPRINT trial that I just mentioned a test of this hypothesis to understand if a lower blood pressure goal might prevent decline in cognitive function or the development of Alzheimer's. I think this is an incredibly intriguing area, and look forward to evidence from that trial. And I'll also mention another timeless question, which is what is the clinical relevance of drug-induced diabetes, specifically increased risk of type 2 diabetes from diuretics. We have, I think, reasonable evidence that it is not the same. Drug-induced diabetes is not as is not of the same consequence as diabetes related to obesity that occurs in the absence of thiazide or induced diabetes. Here are some unresolved issues regarding non-drug therapy for elevated blood pressure. What is the efficacy of lifestyle interventions in children? To me, this is like the holy grail. If we can prevent blood pressure rise in children and adults, this would prevent the blood pressure epidemic. The evaluation of blood pressure independent effects of salt, how to accomplish lifestyle modifications in the clinic setting. We've done some work on that in the POWER study, which documented that you can reduce weight through a remotely delivered intervention, and the effects of dietary interventions in chronic kidney disease, heart failure, and as I mentioned earlier, the effects of carbohydrate on blood pressure. So how has recent research influenced the care of the patient I mentioned at the front end? In the setting of chronic kidney disease, we are attempting to achieve the lower blood pressure goal, that are less than 130/80, and are successful. We attempted the use of an ACE inhibitor. She didn't tolerate it, but we tried. We used a eplerenone, a potassium-sparing agent, as a means to help control her blood pressure. And by the way, it also reduced the need for potassium supplements. The emphasis on sodium reduction as a means to lower blood pressure as well. And so I'll end with some simple advice. This came from Neil Stone, astute lipidologist, clinical preventive cardiologist at Northwestern. Eat less, eat right, move more, and I added one more, take your pills. While I'm a strong advocate of lifestyle modification, I'm an equally strong advocate of medical therapy. We have a lot of evidence, and I believe that promoting adherence both to pharmacologic therapy as well as lifestyle modification is the way to go. Thank you very much for your attention. At this point, I will entertain questions. I understand that individuals in the audience can send me questions entering on the screen at this point. I have okay, let me see. Okay, all right. All right, so let me, okay, I have a question here. How reliable are home blood pressure monitors for the diagnosis of white coat hypertension? That is an excellent question. Ambulatory blood pressure monitors would be considered the gold standard. However, I think there are potential problems with the use of ambulatory blood pressure monitoring. The very practical problem is that they can be used for prognosis, but they can't be as easily used for monitoring therapy since they're typically cumbersome for patients to use. American Heart Association statement has recommended home blood pressure monitoring for monitoring and medication adjustment. I also like using them as for the diagnosis of white coat hypertension. Might be not as optimal as ambulatory, but I think reasonable. And in this case, a diagnosis, a systolic blood pressure of less than 130 would suggest to me either blood pressure control in patients who are who are being treated with medication, or white coat hypertension if they are not being treated. Okay. I thank Samuel Francisco for a positive comment on my lecture. Hopefully others feel the same way. Can you expect the same effects of diet-related blood pressure? I'm not quite sure the context of that question, so if Kali could resend it and be a bit more explicit, that'd be great. I have an individual asked about this individual is interested in the cardio-aerobic exercises. How much blood pressure blood pressure reductions can we expect? That actually is an interesting area. I did focus on diet. Physical activity has been also advocated as a means to lower blood pressure. I think the evidence is a bit more equivocal on this front, and quite frankly, I think is not as strong as for diet. However, I think that there are multiple other benefits, and the available evidence would suggest other reasons for for exercising. So I wouldn't use it as a primary therapy as a means to lower blood pressure, but I would strongly recommend it concurrent with diet therapy. I don't think that they are either or. I think as part of lifestyle modification, most physicians and certainly most organizations would advocate it, but it is not the strongest blood pressure reducing therapy. Okay, we'll continue. Okay, so we have a question about how early should I add another drug and start combination? What about the fashion of calcium and ACE pills? I'm not familiar with any sort of synergistic effect, proven synergistic effect of calcium and ACE inhibitors. One thing for sure is that multiple therapies that block the renin-angiotensin system have not proven beneficial. In fact, there was a recent trial in the New England Journal documented that the addition of a renin blocker had no additional benefit. Renin inhibitor, excuse me, had no additional benefit beyond ACE inhibitor therapy. And there's also been the on-target trial, which documented that no benefit and actually potential side effects and harm from the combination of ACE and ARB inhibitors. Typically, I use one type of therapy that blocks the renin-angiotensin system, either an ACE inhibitor or an ARB. Okay. Does taking medications at night versus in the morning have an impact on decreasing blood pressure? That's a great question, and there actually been some clinical trials attempted, and they've been actually pretty disappointing actually in terms of results. There was a test of whether Kalen, verapamil once daily taking at night had any benefit, and the trial was stopped actually prematurely without an answer to that question. We ourselves have done a clinical trial in patients with chronic kidney disease, and these are, as I highlighted earlier, patients with chronic kidney disease have elevated nocturnal blood pressure, and we did a trial in which individuals took their once daily medications at night before they went to bed versus in the morning, and it had no benefit on nocturnal blood pressure, which was disappointing. So my advice in terms of timing of medications is adherence, 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 and that the reason to time medications is to make it easy for patients to take their medications, to link it with some activity. So if it's in the morning and you link it with, let's say, brushing your teeth, putting on your deodorant, that's great. If it's at night before you go to bed, that's fine. Often, of course, diuretics are not given at night unless they're long-acting, in which case there's very minimal impact. But at this point, adherence is the major driver, I think, for timing rather than efficacy on or preventing events. So a comment that since ambulatory, since there's a question, another question related to ambulatory blood pressure, since ambulatory home blood pressure is expensive and not really covered by insurance, what is a good alternative for patients? So there's a mixture. Ambulatory and home are not, those are separate. So there's ambulatory blood pressure, which is the device put on in doctor's offices that can measure blood pressure over a 24-hour period or longer. And then and that has to be downloaded at a physician's office. That is expensive. Many insurance companies don't cover it. Medicare does, but at a very low rate of reimbursement, so it's not often used. And then there's home blood pressure. Home blood pressure is not necessarily that expensive. You can actually get home devices that have been proven accurate. Myself, I've recommended the Omron device, but there are others. And these devices can measure blood pressure accurately. There needs to be a bit of training to make sure it's done. The appropriate cuff is used after periods of rest. And that is actually pretty inexpensive. The devices can be purchased for under $50, under $100 with features such as digital displays, automatic pumps, and with even interfaces with computer programs and monitoring systems. In fact, I didn't include references, but we published a paper on the use of software by patients that aggregates data across home blood pressure devices. It's in the Journal of Clinical Hypertension, and you can search on me as a co-author. And it actually lists the types of devices and the software available that could be used by patients to monitor their blood pressure over time, which I think is really what's important. It's not just getting the measurement, but actually aggregating the data and presenting it in a useful way to doctors. Next one. Have heard that renal denervation has shown improvements in metabolic parameters and trials in addition. Is this true, and what is the mechanism? One thing that I'm very clear about is I don't answer questions where I don't know the data. I wish I could, and I apologize that I'm not familiar with that evidence. The kidney is more than just the organ that excretes waste. It has endocrine functions. I am not sure, though, about its benefits in terms of especially hemoglobin A1C. Okay, what about drug-induced hypertension, like type 2 diabetes? What about less perilous than organic hypertension? Well, this is really interesting. So are small increases in blood sugar that are related to medication worse than the condition, than the blood pressure levels that people have? And I apologize for the cough, but it turns out that in terms of therapy for patients with type 2 diabetes, we have really compelling evidence that drug therapy for hypertension in patients with type 2 diabetes is incredibly effective, and that includes diuretic-based therapy. So if you give a patient with diabetes, in clinical trials that have enrolled patients with type 2 diabetes who've gotten diuretic therapies, they achieve endpoint reductions that are substantial, highly significant. It's been repeated in several studies, many studies. So that's been proven. What has been very difficult to prove is that improved glycemia control actually has similar benefit, at least in terms of macrovascular damage. And as I pointed out, the ACCORD study did not show benefit There is a major study in Great Britain called UKPDS that showed a benefit of a benefit of in terms of microvascular, and let me underline that, microvascular, but not macrovascular. So, my gut instinct is that if I want to prevent heart disease, stroke in patients with diabetes, aim for the blood pressure. Okay, continuing. What about the role of mind-body medicine in altering blood pressure? That's a great question, and we just completed a review of this for the American Heart Association on alternative therapies to lower blood pressure, non-drug therapies, and it's going to be published in either Hypertension or Circulation in the upcoming months. It is a very comprehensive review, and there is, there's not a lot of compelling evidence, at least for stress reduction types of therapies. The areas where there might be a benefit are aerobic exercise and resistance training. And those are probably the two areas where there is, some evidence to document a potential benefit of alternative therapies. All right. What is the role of wine in hypertension control? Okay. Alcohol and blood pressure. I didn't really highlight the relationship between alcohol and blood pressure. And so there is very compelling evidence, originally starting with the French military early in the 20th century, that a high alcohol intake is associated with high blood pressure. I don't think that's news to anybody. I think the question for many clinicians is, among individuals who are consuming some alcohol, 1 to 2 drinks per day, what is the benefit of alcohol reduction on blood pressure in this range? And quite frankly, the evidence is very sparse, and so I do not typically recommend alcohol cessations for blood pressure control, but I do recommend some moderation. So if women are higher than 2, or higher than 2, or men likewise, that they reduce their alcohol intake. There is an aspect of alcohol that I think people need to be aware of, which is that there's a large amount of calories in alcohol, particularly some drinks, cocktails, and that could contribute to elevated weight. And I think I'm going to end with this question. I believe carbohydrates can cause some degree of fluid retention that can possibly increase blood pressure. Do you have any opinion on this? I think that's a reasonable hypothesis. As I mentioned earlier, there's interest in carbohydrate blood pressure that's responsive to carbohydrates, and I think one of the mechanisms might be sodium retention. And I think I'm still trying to weed my way through these, and I apologize if I don't read your question before the end. At what point in the negative workup of resistant hypertension does one entertain the therapy of renal artery denervation? That's a great question. I actually think that most patients, believe it or not, I think don't require, don't reach the point of procedure, but I almost think that somewhere around 3 to 4 assessment of compliance in which you feel that the patient is taking medications as prescribed and on full dose of at least 3 medications. I think you could consider it, but at this point, quite frankly, I would refer somebody to a clinical trial. I think one of the things that I, as a physician, feel is very important is when we need to get an answer and we have ongoing studies and clinical trials, we should refer patients. So there are clinical trials for such patients. So I'm going to end there. And so I'd like to thank Abbott Vascular, Amarin, Boehringer Ingelheim, Dachi Senko, Lilly USA, and St. Jude Medical for their support of this important educational series. Please remember to complete the quiz at the end of the session to secure your CME credits. My name is Dr. Lawrence Appel. Thank you for joining me today. Have a great evening.